So I have no disclosures of or conflicts of interest, although I should note, since Alan mentioned that I'm recently retired, that I did form my own little like consulting LLC business. I haven't done anything with that yet, but it is potentially, I suppose, a business that I should underscore. Okay, and I also have been very fortunate to receive external funding, both to myself as well as to people within the psychology department at MetroHealth. Have received a large number of training grants and other grants that have helped support some of the work that I'm going to be talking about today. So my goals today is to help clarify some of the lexicon of integrated care, and to help you be able to explain the rationale for integrating behavioral health services, not only in pediatric primary care settings, but also in specialty care settings. And to be able to understand better the models of care and to consider models of care in different clinical settings. When I first started talking about this topic, I used to spend most of the time talking about why we might want to go into primary care. And I like to tell the story that when I first started in my career back at Metro in 1986, and I was invited into the primary care clinic to help coach and teach pediatric residents about psychosocial issues. This was back in 1986. I walked in and I was immediately greeted with just such gratitude. Like, everyone was so happy to see me. It was so reinforcing. And I just thought, why would anyone not want to work in this setting? Because the needs were so great, and my pediatric colleagues were just so grateful, and patients were so grateful for us to be there in the primary care clinic. But these days, I think we've come such a long way in understanding why. And the people that we tend to have to talk about why to are mostly those that need to be convinced because of the business case. It's no longer for clinical reasons, and it's more around why it makes business sense to do that. And hopefully I'll be able to talk a little bit about that as well. This is not a new topic, and people talked about this before I did in the 80s, and beginning with people like Dr. John Wilson, who was president of the American Pediatric Society almost 60 years ago now, 1964. In his presidential address, he said, in noting the problems that he was seeing in the pediatric settings at that time, I feel very strongly that one of the things I would do if I could control the practice of pediatrics would be to encourage groups of pediatricians to employ their own clinical psychologists. Such an approach, it seems to me, is the only practical step to aid us in solving many of the problems of childhood and adolescence. Quite a visionary. And then I also want to pay homage to Carolyn Schroeder, who formed a practice in Chapel Hill, North Carolina in the early 70s, actually. And she's quite a visionary. Carolyn was a former president of the Society for Pediatric Psychology, one of the early presidents, who really took a community approach to pediatric psychology. And she emphasized in this practice a very broad program that involved both, all academics, clinical work, advocacy. She focused on, at the time, what was just an emerging idea of evidence-based, brief, problem-focused interventions. The idea that psychologists needed to be flexible and take on multiple roles, and developed innovative programs like call-in hours and come-in sessions, and developing developmental screening programs, among other things. And she just really would have continued to do this, I think, except that some of the financial pressures in the 80s with managed care, which tended to silo mental health, really made it very difficult to do primary care work for her anymore. I really cherished this picture more recently of her and me together. This was at a PedPsych meeting, I think it was in 2019, when they brought together a lot of the former presidents of the society, and she met with the special interest group, the integrated care special interest group, and really spent just a wonderful session with us talking about her experiences. So always, and she's still around doing her thing, but she's just a wonderful inspiration to me. So thinking now about more current times, The face of pediatrics is this, right? So in a day of primary care, these are the common things that we see in stepping into the pediatrician's office, which are either ranging from normal development to developmental disorders and a whole range of behavior concerns the pediatricians are asked to address in a typical day, which really requires a psychosocial approach. And yet we know we have this legacy of separate and parallel systems of healthcare where we have, in a siloed way, medical care in one bucket, mental health care in another. And everyone's sort of been forced to choose between whether something is medical or mental health. Well, of course, most of pediatrics is not either or, it's really both. And it's very difficult to separate out those sorts of models. And it really has not worked very well in pediatrics or in adult medicine to make that kind of separation. Fortunately, since the Affordable Care Act, things have come and have really started to come together, and it's less of a separate parallel system, but it still exists, still going on today. So why address behavioral health in primary care? Well, first of all, we know that child behavior problems are extremely common, and data from many years have demonstrated that more than half of the concerns that are brought to a primary care pediatrician child visit are psychosocial or developmental or behavioral in nature. School diagnoses of school age and preschool kids that are mental health diagnoses are quite prevalent in primary care, with upwards around 25% of school-age children having a diagnosable disorder, nearly half, 40 to 50%, kids with subclinical disorders that would benefit from intervention of some kind, but may not reach diagnosable diagnosis. And yet we know that most children do not get behavioral health services that they need, that between 70 to 80% of children with a disorder receive no treatment at all. Depending on the study you look at, 50 to 80% of referrals from primary care physicians never make it to their first appointment. And 2/3 of pediatricians, if you ask them, will say we can't access behavioral health care. And how frustrating that must be to our pediatrician colleagues and my colleagues that are out there to say, I can't get my kids seen by mental health. 2/3 of them will say that. Extremely, extremely frustrating. And I think it's important that we recognize that before I go back, we also know that most children will not improve. Most children with behavioral health disorders will not get better, will not improve substantially if they don't get specialty behavioral health assistance. Okay, so some will get better with time, but without some specialty behavioral health assistance, they're really not going to get better. And we know that the only setting that puts children and parents together in regular contact with the child professional is the primary care visit. Now, some of you might say, well, what about schools? We've got schools there and they're with child professionals every day. Maybe that's the setting that we should be focusing on. And I certainly would not disagree. I think schools are an excellent place to receive mental health services. However, remember that most of the data we have on treatments require parent involvement in care of children to be effective, and parents are not regularly available in the school setting. And so that makes it a real problem for really accessing regular and good evidence-based care in the school setting. The other thing I will say, thinking about the importance of intervening when in childhood, and the fact that most will not get help if we just refer them, is that we know that most adult mental health disorders have their start in childhood. And so by not intervening early, we are really missing an opportunity to stop some problems from getting much worse in the future. And then finally, I'd like to remind us that we have good treatments. We have evidence-based treatments that are available for treating most of the mental health disorders that we that we deal with, and there's no reason to believe that these treatments would not work in a primary care clinic as well as they would work in any other setting. There's nothing magical about a room in a behavioral health clinic versus a primary care clinic, as long as you set up the conditions appropriately, and try them out. Now that it is important that we research that and provide evidence, but at this point, the evidence is pretty clear that those treatments work quite well in primary care. I want to mention just a minute about the difference between primary care for adults versus children, because I think this is really relevant to this discussion. In primary care, most of the children who are seen are healthy. They do not have significant chronic diseases. Chronic diseases in pediatrics are still fairly uncommon, and there's a whole lot of them, right? There's just a lot of fairly rare, chronic diseases. That is not true in adults. In adults, there are actually a fairly small number that present most commonly. So diabetes, heart disease, substance-related, obesity and substance-related chronic health conditions really dominate what is presented in adult primary care settings. So when we think about what we might want to do to intervene from a psychological point of view in pediatrics, we're really talking about behavior problems in mostly healthy children. Now, some children with disease, with illnesses and so forth are also included there, but most are healthy, as opposed to with adults in primary care, where really the focus tends to be in trying to address different conditions that impact significant health conditions in adults with chronic health disease. So anxiety and depression, for example, substance abuse, these are all things that really impact health outcomes in adults that are really very different than in pediatrics. Okay, so the other reason that we want to think about this is and why do it in primary care? Well, why the heck not? We have a youth mental health crisis. We need to be thinking about having services anywhere we can. So before COVID, we know that people were talking a lot about the youth mental health crisis in the United States. The US Attorney General reaffirmed this in December of 21, saying we have this crisis, that the mental health challenges are the leading cause of disability and morbidity in outcomes in kids. That a fifth of the children ages 3 to 17 have a disorder. 30% of high school kids have persistent sadness, with 19% of high school students seriously considering suicide. So these are just among a lot of the data that we had about the youth mental health crisis. And the real highlight to this was the fact that despite these concerns that we have with kids, most people have a hard time accessing any treatment for children. So COVID comes along. Did that make things better? No, it made things much, much worse. And so the CDC reported just about a year ago, I don't know, it was in the spring last year, about some results of how the COVID affected high school kids. And what they discovered is that persistent sadness had increased significantly. Now we're talking 44%, 20% seriously considered suicide, and with 9% actually having had a serious attempt. More than half experience emotional abuse. Some of that is 11% physical. We have, of course, a much more awareness of the impact of systemic racism. ED visits for mental health issues increased 33%, really significant in our EDs. And we have been documenting higher risks for mental health issues associated with our LGBTQI youth and youth in foster care and other really high risk groups. So some of this has led people like the organizations such as the American Academy of Pediatrics, the American Academy of Child and Adolescent Psychiatry, and the Children's Hospital Association to declare a national emergency about a year ago. And among the recommendations that they made were several specific to primary care, including increased funding for screening for mental health issues. My favorite, accelerate adoption of models of integrated mental health care, and an increase stepped up efforts to prevent suicide. Okay, so I hope I've convinced you all that it's a good idea to address these things in primary care. Now the question might be, well, what are some of the ways that people have done it? How do you do that? Let me remind you that there are sort of three different um, models of mental health care that are prevalent in pediatric settings. The traditional referral model has the hospital setting, clinical setting on one side, and the doctor's couch being mental health here on the other, and referrals are made to this outside entity. Co-located models would be ones in which you have a medical and mental health facilities within the same vicinity, under the same roof, in the same building, but not necessarily within the same space with the same waiting room space and shared practices. The integrated or more embedded models that I'm going to be focusing mostly on today are those in which you have the couch in the room, essentially, with the hospital clinic. So everything being together. Another way of looking at this is along this continuum of integration, where we see things being on the one end of the continuum more coordinated and consultative in nature. So the idea of, you have some coordination between mental health and the primary care group around screening and navigation and consultation, but not necessarily a co-location of services or integration within the practice. In the integration of practice, I've listed three things there. The COCM stands for Collaborative Care Model, which is a model we'll be talking about in a moment, which is one integrated model. The Primary Care Behavioral Health, the PCBH model of care. And those are probably the two most fully discussed and researched embedded and integrated models. But I mentioned system level integration here in this category too, because sometimes if you pick up a paper or you Google, or you do some literature search on integration, what you'll discover is a paper that really looks at system level integration. So things like Medicare integrated services might mean we're looking at how payments are provided for mental health and medical services. So that kind of system level integration is very different than what I'm going to be talking about today. That's more of a payer integration system level than practice and clinical service. So when one is thinking about setting up an integrated care program, you're all thinking, okay, I'm going to do this. The first step might be to think about those different goals for your setting. What do you want to really accomplish, and which model best fits that, right? So the screen and refer idea is more that coordinated consulting relationship. If you're looking for that coordination the same way, if you're thinking about wanting to access behavioral health treatments on site, that would be both co-located and integrated. But on-demand behavioral health consultation and shared decision-making, that's when you really get into the integrated models. Okay, I hope I'm not going too quickly for you all, but I want to talk now about some of the consultation models that are integrated, but less on the lower end of the integration kind of continuum. Probably the one that's best known in pediatrics is the Massachusetts Child Psychiatry Access Project. And this has served as a model for a number of statewide projects, which I believe includes Florida. And in this model, they have regional teams or hubs that are created across the state, which provide consultation to primary care physicians, either by phone or face-to-face consultation as needed on a as needed basis. And these consultations may also extend to care coordination, some training activities, screening, and so forth, depending on what the resources of the individual hubs are. This really came out of an initiative, it's been quite a while now, more than 10, 15 years ago, where Massachusetts passed a law that said that developmental and behavioral screening for Medicaid had to take place at every single well child visit. And so this was put into place to provide support to primary care docs who were then asked to deal with the results of that. In Ohio, we have a similar network called the Pediatric Psychiatry Network, doctor to doctor line, where you can call that line and get connected. A primary care doc can get connected to a psychiatrist on call. And in Florida, I've learned, you also have the Florida Behavioral Health Collaborative Pediatric Hotline that you can call. And my understanding is that Mailman is part of one of these hubs and provides support services to pediatricians. Okay, so in addition to that, I think I skipped, somehow I lost a slide. My understanding is that there are, I don't know how many hubs, and Alan can maybe share later on what the nature of what you have in Florida are, but that despite this, that those hubs exist, but there isn't as much systematic integration beyond the hubs and the consultation model. Okay, so in addition to so if we go from the consultation model now to the co-located model, the highlight here is really one of physical location. So in co-located models, you can be somewhat embedded depending on the nature of the service, but the really important feature is that you share a roof. And it may vary somewhat in the level of integration and scope of services provided. Now, this has been a very helpful and effective model in a number of different settings. And some of the research that describes integrated models really are describing co-located models and not truly embedded and integrated models. So when you read studies of these models, I think it really is important that you discern what the nature of the services are. It's co-located if it occurs in the same building, but if there's not warm handoffs, which we'll talk about in a minute, and a lot of discussion back and forth between a team of providers, then it's really more accurately thought of as a co-located service rather than an integrated service. That's not to say they're not really helpful. So David Coco and Associates and a number of other people have demonstrated that if you provide services in the same building, then patients are seven times more likely to complete care. That's fantastic. So that's really great. We also have seen better parent satisfaction and provider satisfaction if you provide services under the same roof. At Metro, we have integrated programs, but we also have some co-located services in some of our satellite clinics where we have behavioral health providers in an office nearby the pediatric practice, but not embedded in it. And patients love it. They love being able to come close to where their pediatrician is there. The negative part of that is that if you're not careful, these practices can become very inaccessible, because if you're not providing brief services where you're turning over treatments quickly, if you're providing more traditional kinds of care, then you can quickly find yourself in a situation where you have a waiting list, and then now patients are not able to access the care. So it is important to sort of be in touch with the pediatric practices to make sure if you're providing co-located services that you're still able to meet the needs of the patients. Okay, so what then is integration? Let me just read this. Integration is care resulting from a practice team of primary care and mental health professionals working together to care for the whole child in the context of the family, school, and community. So it's really team-based care in every way. And if you're doing integrated care, then that care can really address a lot of different things. It can address mental health issues for sure and disorders, but it can address any of the other disorders and problems that are listed below, which I will not read, but sort of whatever walks in the door of a pediatrician's office. If you are available to work side by side with the pediatrician, you should be able to be there to help them address any of the concerns that walk in the door. So if that's integrated care, then I want you to think about that in connection with the collaborative care model or the impact model, which is one model that is often discussed in integrated care conversations. The collaborative care model is a model that really came out of the adult literature. It came out of work out of Seattle, out of University of Washington, where the behavioral health folks were working together with adult primary care docs, primarily older adults, providers of older adults, to look at improving the outcomes of depression and then later anxiety in primary care. So if you recall, I talked about how depression and anxiety in adult settings really has a negative impact on health outcomes in adult primary care. So this was really developed to be able to help provide support for adult primary care docs to better treat depression and anxiety when they had limited supports in any other way. So the focus in collaborative care models is really on depression or anxiety in order to impact outcomes. The main feature of the collaborative care model is a consulting psychiatrist or behavioral health medication specialist and a care manager within the practice who can consult using a PHQ, the Patient Health Questionnaire, screening of depression to help manage a registry of patients. And the consulting psychiatrist is really on hand to provide support to the providers to help them with better prescribing of antidepressant medication. Whereas the care manager in the clinic, who could be a nurse or a social worker or or any trained person who has received special training in this area, is responsible for keeping track of the screening register, possibly meeting with the patients in person or by phone just to see how they're doing and maybe making some recommendations with a step-down algorithm tip sheet, but they are typically not trained behavioral health specialists. The key to this is tracking outcomes through the repeated use of this registry using the PHQ-9. Now, there have been a number of studies, quite a few actually, with adults that have demonstrated that this is very effective in treating depression in primary care. And it's been used in other areas such as not in cardiac conditions, diabetes, anxiety, and some other areas. There have been a couple of studies with kids, but not too many, to be honest. Now, the thing about this program, this model, I should say, is in this picture, hopefully you can see this, is that it really kind of focuses here on this primary care patient care manager grouping, okay, with that psychiatry consultant on the outside being available. The behavioral health clinicians are not seen as being critical to this intervention. So you can have them in the model, but they're not really critical to the model per se. Okay. One of the problems with the collaborative care model, in my opinion, for pediatrics is that if you're focusing only on depression or only on anxiety, you're really missing a lot of the other things that are coming through the door for in pediatrics. So the primary care behavioral health model, PCBH, is one that really tries to optimize access for behavioral support across any domain. And it's used usually by having a behavioral health consultant that could be a trained psychologist or a well-trained counselor or social worker, therapist who works alongside with medical providers in real time. And typically things start with a warm handoff where the patient will see a physician first, and then a behavioral health clinician is brought in to help intervene on the behavioral health issues and provide support for not one condition, but really a broad array of mental health and physical health concerns that might come. The goal for this model is to really improve access to behavioral health care and improve conditions, regardless of what comes in the door. So this is a graphic provided by the American Psychological Association about integrated behavioral health care that says, for anything that comes, for integrated care really is for any problem patient has come to the right place, the idea that there's no wrong door. In order to do this, interventions have to be quite broad. And so in integrated care settings, you will often find a vast array of different kinds of interventions that can be provided. And so the skill set of the individuals who are working there has to be pretty broad to be able to address all of these things. So it can range anything from screening, prevention to chronic disease management and crisis management. We, on a daily basis, deliver all of these things in our clinic. So the model in practice might look something like this. So you see the primary care doc is in the clinic with the patient, and the patient says, you know, doc, I'm feeling upset, sad, anxious, what have you. The doc says, let me see if my psychologist is here. Whoop, there's Dr. Stancin. Okay, Dr. Stancin, I've got this patient. What do you think we should do? And I say, well, I think maybe if the patient is sad, let me go and I'll do a warm handoff. So then the doc goes back in, says, you're in luck. Dr. Stancin is here today. Let me go get her. Dr. Stancin comes in, says hi. Doctor goes out. We talk. We establish a rapport and a plan, and then hopefully patient starts to be on his way to be better. This is the contrasting model of primary care, the behavioral health model, where you see here, instead of having a care manager in a key role, we have a psychologist or behavioral health specialist in the role as a partner to the primary care doc and the patient, with a care coordinator, you know, possibly involved as well with the care of the patient, who can be in consultation with a psychiatric or developmental behavioral ped consultant to provide medication and other consultation as needed. So I won't go over this chart with you too much, just to say that there is a lot of overlap between the primary care behaviorist model and the collaborative care model, but I think you get the point here that the main difference is that in the primary care behaviorist model, there really is a focus on having a well-trained behavioral specialist embedded to deal with what comes in the door. And in the collaborative care model, where perhaps there is no behavioral health specialist available, the focus is much more on using an algorithm-based step care approach with screening and registries to try to focus on the most on a targeted symptoms such as depression. And you know, I think in a primary care setting, you know, ADHD might be a condition that could be used for this, or depression. But I think there have been some studies with depression with adolescents in this case that have found some support for it as well. So one example of a comprehensive model is the Boston Behavioral Health Integration Program, the BHIP. This study was published in a number of places, most recently in Pediatrics in 2019, describing a really massive coordinated project with 13 pediatric practices associated with Boston Children's Hospital in Boston. And they provided an integrated model that really did it all. They did embedded, they had, you know, an embedded team, ongoing behavioral health education for their providers, on-demand psychiatric consultation, and they looked at 5-year outcome data with this particular model. And in the results are it's very hard to do this kind of outcome study, I just tell you, very difficult. But what they were able to demonstrate was really some pretty impressive findings with increased access to behavioral and medical behavioral health visits, just much improved prescribing practices by the primary care docs on their own, just getting much more comfortable with their own prescribing, a decrease in emergency mental health spending as associated with this, and significantly high provider satisfaction. And there's a number of other outcome measures that you can see if you want to look at this study, but it's really quite lovely that demonstrates, if you do pull out all the stops, that you can find in some significant outcomes. And my understanding was that in terms of cost savings, it didn't, I don't recall that it saved a lot of money, but it also didn't cost a lot of money. So I think it was able to improve outcomes without really highly significant increase in costs. The Healthy Steps model is another kind of model of embedded services. And what I like about this model is that it uses sort of a tiered approach that emphasizes prevention more. So in tier 1 services, everybody in the practices receives universal screening and child development support that's available to everybody who walks in the door. But then tier 2 supports are those where the patients are identified with mild concerns and need a little bit extra support. And they're targeted and screened with a variety of different ways. They're through screening measures and referral sources. And they get all that everyone gets in tier 1, plus some additional therapy supports. And then tier 3, those are the ones who are at most risk, and they get all of 1 and 2 tiers, but then they get much more intensive preventive team-based well child care visits. So what's happening in Florida? This is actually on your Florida Department of Health website. I don't know if it's up to date completely, but it looked pretty good. And what the Florida Department of Health states is that it recognizes that Florida has a problem getting kids access to mental health care, and that only half of the 400,000 kids who need services are having any access to it. So the quote I have for you here is that they're recognizing that integrated behavior care is really important, and they value it. And they do describe the 3 models that I just talked about: the referral, collocated, and in-house kind of embedded models. Those are the terms that they use to describe the models. They don't describe actually providing all of those different levels and models of care, but they do describe the Florida Pediatric Mental Health Collaborative that I referenced a little bit earlier, that I believe your center is a part of. And that's where this notion of having hubs, and then the regional hubs, and supporting the practices and the parents through these different initiatives. And I've just listed those for you there so that you know that you get recognized for the work that you all are doing. Okay, so what do we know in terms of how effective all of these things are? Well, there have been a number of studies, and we could use more, to be honest, that look at how specific conditions such as ADHD, depression, anxiety, and so forth, how effective are treatments in primary care. And all of the studies that I've seen that have looked at it have demonstrated that if you're using an evidence-based treatment and you're doing it in primary care, it's just as effective. And you tend to get people coming for treatment and completing treatment much more likely. So really good results there, good results in suicide screening and management, as well as health behavior change and some prevention issues as well. Every study talks about the fact that the most important thing that integrated care does is improve access. So patients are much more likely to receive and complete services if the services are provided in their primary care setting. I think what we're going to start seeing now that we don't have to prove that it's a good idea is really looking at more what works. Research supports all the models work. The co-location and integrated models have more evidence for effectiveness, quite honestly, than the consultation models do. But I think that we're going to be able to see that, really anything is better than nothing. And with changing healthcare business models, with share of wallet and other things that I'm hopeful that we'll be able to talk more about prevention in integration and be looking at what works better in use of those settings as well. In the interest of time, I just want to mention that if you're thinking about putting together a model, whether it be embedded or co-located, that it's really, really important that you create a business model for this, where you examine all of the factors that I have listed above, including space, staff, etc. When I went to set up different practices within our MetroHealth system, even though we knew a lot, we still had to go through each site and look at these issues for each site to examine what the patient needs were, the provider training, and so forth. And also, really, really importantly, available workforce. And in just a little bit of time that is left, I want to just focus somewhat on that issue of workforce. You can't just take any sort of garden variety mental health person and plop them into a pediatric setting and expect that they will know how to work in an integrated care setting. And likewise, if a pediatrician has never worked with a psychology or mental health folks in a collaborative way, they will really struggle with knowing how to do that. So we found years and years ago that it was really important that we try to help residents and our psychology trainees in our setting learn how to work together by creating training programs that overlapped. So in case you don't know much about MetroHealth in Cleveland, why would you? MetroHealth, you can see Cleveland is way up there near on Lake Erie, that little red dot up here. And we are experiencing fall already. It's already cold. It's in the 50s today. But Cleveland is a city that is well known to be a city where children live in poverty. We have a lot of risk factors for our children being exposed to violence and discrimination. And we have some of the worst health outcomes for kids in the nation because of all of those reasons. So MetroHealth is the county safety net medical system for this region. So we have a very difficult patient population at Metro. We are an academic medical system associated with Case Western Reserve, where we have over 100,000 ambulatory pediatric visits per year to our system in 25 different locations. But most of the children that we see are actually served currently on our main campus location. And our patients are, as you see here, a Medicaid patient that are racially and ethnically diverse. Our model has been around for quite some time, but this is a snapshot of it. So what we have in our clinic is we have a clinic where we have our primary care clinic staff, which is residents and our primary care general pediatrician attending continuity clinics and their pediatric clinics going on. But really in the same general vicinity, we also have specialty clinics. So at the same time that we have primary care going on in one hall, we'll have our diabetes clinic or our neuro clinic or our cardiology clinic going in another hall, and our urgent care clinic down yet another hall. So we have a lot going on in our clinic setting at any given time, with a lot of pediatric providers running around. Well, enter our integrated ped psychology team, and we are able to staff in our clinic 5 days a week, all day long, a team of pediatric psychology attendings and trainees. We have at least a minimum of 1 faculty member, sometimes 2 on staff, depending on what's going on. And we'll have at least 2 or more psychology residents and fellows who are on site at any given moment. And what we can do in this setting, because we have enough providers, we have this delicate dance of having warm handoffs, same day consults, brief problem-focused treatments, and risk and suicide assessments that go on. We do have a consulting relationship with a child psychiatrist that we have worked out a process for, which I will not have time to go into today, but it's worked out quite well for us. We also have specialty clinics that have embedded teams of psychologists in as well. And I believe you have similar kinds of models at Mailman in your specialty clinics. I won't go through this right now, but this is just a snapshot of a typical afternoon of our team from huddle to the end of day, where we're kind of doing our thing. The reason I want to point this out is that at the end of the afternoon of this particular typical day, with a preceptor, a psychology faculty, 2 trainees, and then some other observers, we were able to have at a minimum of 4 to 5 billable encounters for that afternoon, which justifies and pays for the cost of our service. This slide is just briefly to tell you that we've been looking at our suicide risk assessments. We have a paper coming out on this finally in the Journal of Developmental and Behavioral Pediatrics. It's in press. But the reason I'm so excited about this is that what we were able to do with our embedded team is we're able to manage suicide risk assessments almost all the time. So over 90% of the time, that kids who would have been escorted to our emergency room because they had significant suicidal ideation, we can assess them, stabilize, and manage them outpatient without sending them to the ED. Only 7% of the patients in this study period actually had to go to the ED for hospitalization. What we were also able to show with this study was that if we do all the fancy math and you look at all of the costs that are associated with this service, that we were actually able to save the hospital a significant amount of money per patient. And what we were told when we did this analysis, that just really with our suicide management alone, that we more than covered the cost of our primary care behavioral health services in our clinic. So I want to make sure that I stop here to leave some time for questions. There are some new topics that are coming up that I'll just kind of put there for your to be looking at while I stop for questions. But I am very excited about the fact that integrated care has now become really a popular topic in not just pediatric psychology, but in mental health across different disciplines, that there are more funding opportunities for workforce development that are out there, that there's more research going on, there's some promising funding streams that are out there. And so it felt like a good time for me to be able to retire. I sort of delivered this, my model, and I'm leaving it to all of you to now take it over from here. So let me stop. And I hope you have some questions over that whirlwind of discussion that I just presented.
Thanks, Terry, so much. It was a great whirlwind. And we know about whirlwinds down here in Miami, but that was fantastic about all the models and all the issues, and particularly enjoyed hearing about your program and how you developed it in MetroHealth. And you mentioned just real quickly that you really are using a fee-for-service model in terms of billing. So you get at least 5, maybe even more billable hours. But that's something that is targeted towards the Medicaid patient in Ohio. And
it is.
It apparently doesn't require pre-authorizations. You just kind of just bill it, and you get reasonable compensation for the efforts that your team provides. We do, and we actually are able to. We more than can cover our services with our billable encounters. So our hospital has been very supportive of our model, and we've really expanded it greatly over the past few years. Yeah, no, it's in it, and it not only are we able in Ohio, we may have a different situation obviously than you have in Florida, but not only are we able to do that, but we've been able to be more competitive for the pediatric market share because of what we provide. It's very hard to access pediatric mental health specialists in Cleveland, as I'm guessing it is in Miami. And so what we found is that we get a lot of families, either privately insured as well as Medicaid families, coming to our pediatric practices because they've heard that you can access mental health on the same day, and the concerns they have are relevant to mental health. So we have been, the pediatricians love us, and they have said that they refuse to practice without having us involved in their services because of that. That is music to the ears of Dr. Brosco, who has his hand up right now. Dr. Brosco.
Okay. Hello.
Hi, Terry. Thank you so much for a wonderful presentation. I just want to make a couple of comments about both the federal and the state level, and then ask you about telehealth. So I'm putting in the chat right now, I think if I do it correctly, let's see if it works, that just 3 days ago, Secretary Becerra pointed out that the key pillar in the federal response to mental health issues in the United States is behavioral health integration. And there is an entire roadmap of all of government involvement in trying to create exactly the models you were talking about for both adults and children. So this, as you're retiring, it is the big time, as big as you get. And just to comment about what we're doing at the state level, because you asked about that. And we're actually allowing the different hubs to use different models. And it's far beyond the Massachusetts or Ohio models of just a consultation. It's really working about pediatric practice transformation. And awesome. Allowing each pediatric practice to figure out what, given their resources, is it a fully co-located integrated model? Is it having some other version of that? Whatever their local resources are, because as you know, we probably need 100,000 more psychologists to do what you're doing in your model across the country. country.
Yep.
I guess my key question for you is the one, well, maybe not one good thing, but one good thing about COVID has been that we suddenly can do telehealth. So this morning I saw a kid that was a concern about autism, and the speech pathologist joined us. And then there's another child where they were having some behavioral intervention, and the behavior specialist joined us. Just ad hoc, we all got in the same Zoom call. What do you think this will mean for the future of physical co-location as opposed to, well, can we just, co-locate virtually, and does that get us in the same place? What's your guess on that?
Yeah, I'm so glad you brought that up. So during COVID, when our pediatric clinic was completely shut down and they were only doing telehealth, our primary care team, we were like, well, what are we going to do now? So we rapidly flipped to telehealth, and we developed a method of providing telehealth primary care visits for our patients. And so we worked out a really great system of doing that. And what we learned from that is that this kind of a hybrid model where you can do both co-located, on-site and telehealth is a really terrific option. And it's better for warm handoffs are better in person. So having a warm body there works out a lot better than trying to warm handoff to a telehealth person when the patient is there. That's been our experience. But if we don't have a behavioral health person in that particular clinic that day, we're able to access them through telehealth in their home. And so there's such great advantages to being able to see patients in their home through telehealth. We absolutely love that. So some way of doing maybe warm handoffs when we first meet the patient, get to know them in person, and then providing some telehealth, offsite in their home, or sometimes in the school, the kids can step out and do it in the school. Those things really are very helpful. And I do think that, in the future, when, you're someplace where there are no behavioral health providers anywhere in the region, you're in, I don't know, Idaho, and you can't find anyone, you'll be able to reach out to regional experts that are not going to be able to be in person. So I think telehealth is really been a game changer in mental health for us, but it really has not replaced in the priority. It's better, we find, if we can at least make that in-person contact for the first visit, if possible. I don't know if that answers your question.
Feel free to use the chat if you don't want to speak up. Just put it in there. One thing I'm just curious, Terry, what your thoughts are about the fee-for-service model, given the evolution of integrated care models. Do you think are we seeing the end of it? Are we going to end? Because fee-for-service does require a diagnosis to provide. So all the little consults, tier 1, the tier 2 even, may not be reimbursable. Right. Yeah,
it's interesting. What we find is that most of the referrals that we get in primary care we can attach a diagnosis. That the ones that are really subclinical and really you cannot provide a diagnosis, we tend to coach we either eat that cost or we refer them to other agencies or organizations that can maybe manage it as a prevention strategy. So I think we found that more than 80% of the referrals that came to us in our study were billable. So it's really a fairly small percentage. You'd think that we would get just undiagnosable conditions, but I think the prevalence is so great of diagnosable disorders that really most of them can be billed as fee for service. Yeah. With your question though about the change, I thought we'd have more than by now. I mean, after the Affordable Care Act, I thought we were going to have more of these sort of models where we had share of wallet and different kind of funding mechanisms. Medicare is doing a better job at that than Medicaid, I think. But we'll see how that's going to go. Prevention is very hard to convince people, especially with kids. I think with kids, the return on investment is so far out that funding is so in the now that it's very difficult with kids to be able to get a lot of those things funded.
Well, we are unfortunately out of time. It's already after 1 o'clock. I want to thank everybody who's been here today for this terrific grand rounds for the Mailman Center. Thanks so much, Terry Stancin. Really appreciate it.
Well, it's my pleasure. I'm sorry. I think I went on a little long. I would have loved to have been able to have
You could talk all
time.
Afternoon about this.
We could. We could. Well, bring me back informally to talk to the group. I'd love to.
Good.
Thank you,
all.
Joe.
Have a great day.
Thank you.
Okay. Bye-bye. Bye.